Hello everyone. Today we'll discuss a very important topic, dosing in elderly patients. This is something which is you must know. So let's get start with the introduction. Aging brings about significant physiological and biochemical changes. So as people age, their body goes through changes. These changes can affect pharmacokinetic and dynamic of drugs. Means it affects ADME of drug absorption, distribution, metabolism and excretion. So if we give a normal adult dose to elderly patient, it can lead to serious side effects, ADRs or even toxicity can occur. So that's why we need to individualize the dose in geriatrics. There is a simple way to classify elderly patients based on age. So 65 to 74 years young old, and 75 to 84 middle old, then 85 years and above old. So you can remember by adding 9 or 10. Okay, 65 to 75, actually 75, but we cannot include 75 as we are taking 75 here, so we have to take 74. So 65 to 74, 75 to 84, then 85 to above old. So this helps the doctors to estimate how vulnerable a patient might be to drug effect. Now here, why dosing in elderly needs special attention you can understand. Because of increased prevalence of multiple diseases and chronic diseases, polypharmacy is common. They take multiple medications and their organs are very weak, and increase risks of drug accumulation, and which leads to toxicity, and they are more prone to get side effects. You can remember this importance as C port. C means chronic diseases and P means polypharmacy, O means organ function, weak organ function, you can remember. Then R means risks, what risks, toxicity risks, accumulation of drug risks. Then T means tolerance, they cannot tolerate the drug, so side effects are more. And age related physiological changes, here you can see if body water decreases because of age, body water, total body water decreases. So what happens, it increases plasma levels of water soluble drugs. Then body fat increases, so it increases half life of fat soluble drugs. Then serum albumin, it decreases, and if it decreases, what happens to protein bound drugs, their free drug concentration will increases, which accumulates and causes toxicity. Then hepatic blood flow, which is decrease with the age, so first pass metabolism also decreases. Then the GFR also decreases as the age increases, so renally excreted drugs cannot excrete properly, so drug accumulation is seen. You can remember this table as way for W for water, then A for albumin, F for fat, E for extraction ratio. You can remember the extraction ratio, and R for GFR, renal clearance. Now let's go step by step through pharmacokinetic consideration. First, we'll discuss absorption. No, it is not much change, but gastric pH increases and blood flow decreases, which may delay drug onset. Usually, it does not affect absorption. Okay. Then we have distribution. So, water soluble drugs increase plasma levels. Fat soluble drugs stay longer and increases half-life. Example for both each aminoglycosides and diazepam. Then we have metabolism. Phase 1, phase 2. Phase 1 means oxidation reduction and phase 2 is conjugation, which is decreased, and here it is mostly preserved. So the drugs, okay, so the drugs like diazepam stay longer in the body. Then we have elimination. Renal function gets dropped, decreases. So we use equations to estimate kidney clearance. Here we are using Cock-Crofts-Gault equation, which is creatinine clearance equals to 140 minus age into weight. If it is a female patient, then you have to multiply it with 0.85. If not, then just divide with 72 into serum creatinine. Just remember, most of the formulas have serum creatinine. Okay, in denominator they have serum creatinine. You can remember this formula like age and weight. It is a common term. You have to include age into weight. Then serum creatinine, as I said, that most of the for all the formulas have that in denominator. Then here you have to put 140. If you are putting 140, then what will be the half of it? 70. So 72 you have to keep here. So what it becomes? 140 minus age into weight divided by 72 into serum creatinine. If it is a female or if it is a black race, so then you have to multiply it with other terms. You can write just this or you can include this also. And make sure to calculate this before giving renally cleared drugs like digoxin, aminoglycosides, etc. Let's talk about how the effect of drug changes, which is pharmacodynamic changes. Now CNS sensitivity increases. They become extra sensitive to benzodiazepines, opioids. Beta receptor response decreases, so beta blockers don't work as effectively. Then baroreflex decreases, causes postural hypotension, feeling dizziness after standing up. So increased risk of postural hypotension can be seen. So the general drug classes requires extra cautions are benzodiazepines, they cause sedation and confusion. Anticholinergics, they cause a delirium, urinary retention, dry mouth also they cause. NSAIDs, GI bleeding, kidney damage they cause, and digoxin arrhythmias, visual disturbance, sulfonylurias, prolonged hypoglycemia, that means long lasting hypoglycemia, and antihypertensive drugs that causes dizziness, falls, postural hypotension, etc. So you can remember this table as bad NSAID, sugar. Sugar is also bad. Okay. So B for benzodiazepines, A for anticholinergics, D for digoxin, NSAID means NSAID. Here sugar stands for sulfonylurias and antihypertensive. Hope this helps you. Now the dosing strategies. Always follow this golden rule. Start low, go slow. So here is your strategy. You start with the low doses and avoid unnecessary medications and adjust the dose based on renal and liver function. You can prefer once daily dose and regular monitoring is must. Monitoring is must. You have to watch for toxicity, ADR signs, drug levels, and uh, organ functions and enzymes levels. There are tools to help us prescribe safely. First one is Beers criteria. It lists drugs to avoid in the elderly patients. Example, to avoid long-acting benzodiazepines like diazepam. Then we have stop-start criteria. Stop screening tool of older persons' prescriptions. It flags harmful drugs prescription. And start means screening tool to alert doctors to write treatment. It reminds us to prescribe needed drugs, alters for under prescription of essential drugs. Only that which are needed drugs, it tells that to prescribe that only which are needed. Together, they help avoid both over and under treatment, and treatment failure and toxicity are also avoided by these tools. Here, what we need to keep an eye on, which means we have to monitor the serum creatinine and LFT, ECG, drug serum levels, BP, HR, cognition. Alright, so dosing in the elderly is all about customizing the dose, and we must understand their body changes, use clinical tools like these criteria, and monitor regularly. Always keep the mantra in mind that start low, go slow, monitor often. If this helped you to understand the topic, don't forget to like and share this video with your pharmacy students, pharmacy friends, and subscribe for more videos.